Just a reminder for guests who we hope will continue to participate. Sign-in sheets to the right side. There's also a QR scanner, so if you have a smartphone, you can download for free a QR scan. It takes you directly to the site, and you don't have to, actually it frees up Veronica from inputting it. Today we'd like to welcome Dr. Samy Riad. Dr. Riad presently is the medical director of the kidney transplant program at Christus Transplant Institute, and soon to be the interim medical director of the pancreas program at University Transplant Center. Prior to his arrival here, roughly about a year ago, he was at the University of Alabama as assistant professor of medicine, involved with nephrology and the transplant service. And prior to that, where he did his training, University of Minnesota, where he did his nephrology fellowship, fellowship in transplant nephrology, and a master's in clinical research. We work with him very closely, the surgeons, and today he's going to talk to us about antibody-mediated rejection in kidney transplantation.
Thank you for having me. Good morning, everyone. Today we will talk about antibody-mediated rejection. This is the outline of the talk. We'll go through a brief introduction, some definitions, pathophysiology, outcomes, and therapeutic options. So we all have noticed over the last few decades that the one-year graft survival have improved tremendously owing to the multimodal immune suppression therapies. Decreased early acute rejection in the cellular blend. However, the long-term 10-year survival remains unimproved to a large degree. Antibody-mediated rejection, that will be referred to as ABMR throughout the talk, is a barrier to improving long-term outcomes. So this slide depicts the outcomes and causes of graft failure. This is a study by Sealer's group, 315 consecutive biopsies were done for cause between 6 months and 32 years, and patients are followed afterwards to ascertain the reason for the graft loss. So depicted in red, greater than 50% of the allografts showed antibody-mediated rejection. Here in green, this is polyomavirus accounting for 7%. Medical and surgical causes for a smaller portion, GN causes for roughly 18%. In addition to that, there was probable ABMR for 9% and mixed rejection, making 64% of all graft failure causes attributed to antibody-mediated rejection. Of those, roughly 47% are due to non-adherence, and 53 were ascertained as adherent with therapy. So what are the types of ABMR? Hyperacute rejection that happens within minutes. That's essentially of the past now. It's usually due to preformed donor-specific antibodies and high titers, largely avoided due to pre-transplant cross-matching. Acute ABMR, which usually takes place within days, usually happens in the setting of Novo, DSA, and chronic ABMR, which is the cause for unimproved long-term survival. Briefly, with the pathophysiology, so this is some of the results of the DCAF genomic, which essentially it's a cross-sectional cohort where everybody got biopsied, followed for a longer period of time, and they tried to ascertain the long-term allograft survival by C4D and DSA. So if the biopsy showed C4D negative, DSA negative, these are the folks depicted with the top line here, and C4D negative DSA have little more worse survival. That's perhaps due to de novo versus preformed DSA. C4D positive DSA negative had poorer survival, and the worst survival was reserved for C4D DSA positive group. So the mechanism of donor-specific antibody-mediated endothelial injury depicted in this slide, where there are antibodies early on that attach to the major histocompatibility antigen on the surface of the endothelium, triggering proliferation and release of cytokines and others, activating the complement pathway, releasing more enzymes and chemotactics, attracting macrophages, natural killer cells, and polymorph in different lymphocytes. And this is what usually gives us peritubular capillaritis. So this is a kidney biopsy with peritubular spaces that show dilation and attachment of lymphocytes to the wall. Carrying on with the pathophysiology of the ABMR, we have complement activation leading to the deposition of the C4D. Now with the C4D, by 2013, Banff acknowledged ABMR C4D negativity for various reasons. So this is also a depiction of the complement pathway, the classical and the indirect, leading to the C4D. Now, the antibodies dissociate more rapidly than the C4D. However, the C4D has a number of shortcomings as why it shows or does not show on the biopsy when ABMR is suspected. There are two ways that we stain for the C4D: immunohistochemistry that appears to perform less briskly than immune fluorescence. There is waxing and waning nature for the C4D, and some of the stability of the molecule factor in why it may not appear on the biopsy. So over the years, the evidence was compiled as to why C4D may not make you or break you for diagnosing ABMR until it reaches its peak. And by 2013, Banff decided to acknowledge ABMR with C4D negative stains. So historically, we defined antibody-mediated rejection based on 4 criteria. These are neutrophils in the peritubular capillaries, or also known as peritubular capillaritis, de novo DSA formation or detection of DSA, C4D positivity, and graft dysfunction or ATN present on biopsy. Here's the meeting report from 2013 defining various types of rejection that we deal with. So acute active antibody-mediated rejection, it requires presence of 3 features, main features for diagnosis with different criteria. So histologic evidence of acute tissue injury, that's usually defined as microvascular injury. This is in reference to presence of inflammation in the capillaries, which are present peritubular or in the glomeruli, small fine vessels, intimal or transmural arteritis, acute thrombotic microangiopathy in the absence of microangiopathy causes other than immunogenic, and acute tubular injury or ATN. Evidence of recent antibody interaction with the vascular endothelium, and in 2013, Banff acknowledged genomics and gene expression studies within the biopsy. There's a group somewhere that you can submit your tissue, and they run different genes and tell you what's going on in the biopsy to some degree. However, it's not quite timely. Nonetheless, if it if you have evidence of microvascular inflammation or antibody interaction with the endothelium, that's one of the criterion. And circulating donor-specific antibodies detected by the usual methods. Here, this is a biopsy showing peritubular capillaritis, more brisk, and this is the immune fluorescent C4D. That would be a peritubular space staining the edges, the C4D present and delineated, and this is a tubule with the basement membrane showing the C4D stain. Now, moving on to chronic active antibody-mediated rejection, the hallmark of chronic antibody-mediated rejection is the inflammation or the chronic inflammation present in the glomeruli or the peritubular spaces. In the glomeruli, they coined the term transplant glomerulopathy, which is characterized by the duplication of the basement membrane, and this is when we start seeing protein in the urine clinically. Same thing with the evidence of current or antibody interaction with the vascular endothelium, as well as identifying the circulating donor-specific antibodies. All three must be present for the chronic active diagnosis. And this is in this slide here, this is the appearance of the glomeruli showing transplant glomerulopathy with the double contouring and the thickening of the capillaries. Here, this is duplication of the basement membrane on EM, and this is multi-layering within the peritubular capillary space on EM, signifying chronic injury, ongoing injury. And in this slide, this is a depiction of all different kinds of antibody-mediated rejection. And again, the take-home message, C4D, negative ABMR is a well-established entity, and it exists due to the waxing and waning nature of the C4D molecule, as well as the other causes we touched on. So, in regards to donor-specific antibodies, that remains a large area in our field. Donor-specific antibodies are formed for various antigens. HLA is what we have most of the knowledge on in the field. It takes place 10 to 20% on the Novo basis or pre-existing before the transplant. Other antibodies can be formed to endothelial structures and different receptors, and this is an area that I suspect is going to proliferate, and we will know more over the next several years. And other parts of the organs, such as Vimentin in the heart or ICAM. So in this diagram, it shows different antibodies determinants. Subclasses is an area that is being explored. IgG antibodies versus IgM, glycosylation at different sites, antigen densities, and different epitopes and cross-linking, and concentration of the antibodies. The effector portion of the antibodies, such as the FC portion, the capacity to bind C1q or fixed complement, and HLA cross-linking. Other mechanisms that antibodies causes injury through recruiting different cells of different white cells, complement activation, endothelial activation, leading to the C4D positivity or macrophage infiltration or endothelial changes. So here on this study by Lupi that came in late 2013, and this was one of the studies that depicts that all donor-specific antibodies are not the same. Meaning some are more injurious based on the mechanism of how they cause their injury. So here, Lupi had a cohort of closer to 1,000, looked at the allograft survival according to DSA, DSA negative versus DSA positive. Depicted on the top line are the DSA negative had good survival as compared to people with DSA positive were on the bottom. And now the capacity of the antibody to fix complement or bind to C1q carries far more worse prognosis, depicted here in the red line. Folks with DSA that fix complement has lower probability of graft survival. And that's now a readily available test that can be done. However, these results were not reproduced by others. This study comes from France. Now, moving on to a different antibody types, which is antibody to the endothelium. This study from Poland, and it depicted, so essentially they had about 117 consecutive biopsies, and retrospectively looked at their sera and tried to find if who had the antibodies towards the angiotensin receptor 1, and they found the angiotensin receptor titers high in 27, and then they looked at the degree of the rejection. So of those who had the antibodies towards the angiotensin receptors, they had severe rejection, 2B, or antibody-mediated rejection. And of these, 3 had arteritis, compared to 1 in 90 in the other group who did not have the angiotensin receptor antibody. More on this is coming, I suspect, in the next couple of years. Moving on outcome. So we're going to go through a series of studies to delineate different types of donor-specific antibodies, PRAs, and the outcome on the allograft. In this Kaplan-Meier, these are 334 patients with CDC negative cross-match. 67 of them were retrospectively determined to have preformed donor-specific antibodies by flow cross-match. And this is the probability of antibody-mediated rejection. Those who are depicted in pink or red had closer to 55% probability of antibody-mediated rejection by 100 days on protocol biopsies, and continued to carry on as compared to those who did not have the donor-specific antibodies. Pre-existing and de novo DSA can differently affect the allograft and have different outcomes. Pre-existing DSA, here in this study, it depicts the graft survival. So here I refer to anti-HLA. You can think of this as PRA. So people who had no PRAs, no DSA, carries the best survival as compared to those who have some PRA but not without the specificity to their donors, as compared to those who have PRA and donor specificity who carry the worst allograft survival. De novo DSA, whether the donor-specific antibodies were formed in a de novo fashion or a pre-existing, it carries also worse prognosis for the people who form de novo have worse outcome.
Samy, can I just ask you a quick question on that slide before we move on? Those patients that had who had PRA donor-specific antibody in the study, do they comment on, do these patients have a positive flow cross-match at the time of transplant?
No, these without positive flow cross-match.
Okay, so MFAs not to the limit that would have caused or not to the degree that would have caused a positive cross-match.
So these are PRA and have no DSA, and this is de novo DSA.
Okay.
So this is not transplanting with the presence of pre-existing donor-specific antibodies with negative cross-match, which roughly carries a chance of 25% rejection within the first year. So here in this cohort, these are cohort of siblings who have HLA or 2 haplotype match just based on A, B, and DR, without the fancy class 2 DP, DQ. And here, this is their outcome over years and the chance of graft survival. In black, no PRA have carried the best survival. Folks with PRA 1 to 50 had lower survival and significantly lower survival for those who have higher PRA among siblings with two haplotype match. So PRAs carries risk. So this is also, this is a protocol biopsy series looking at subclinical AMR, meaning that AMR, the inflammation is present, creatinine is not reflective. Suspicious AMR, which is not all 4 criteria were met that we mentioned earlier, and no AMR. So here, CAN is, was the score that the Banff used to quantify the degree of the graft dysfunction or failure histologically. So those on the early biopsy, those who had subclinical ABMR, their CAN score was good. Fast forward a year, those with the subclinical, even subclinical ABMR was associated with worse fibrosis by 1 year on biopsy. In a similar study, they looked at the subclinical antibody-mediated rejection versus the suspicion for antibody-mediated rejection versus no antibody-mediated rejection with on the impact of the chronic change. EFTA is interstitial fibrosis and tubular atrophy, the scheme that replaced CAN. And we see those who had, even the subclinical AMR had lots of EFTA as compared to those who were suspicious for AMR as compared to those who have no AMR. And transplant glomerulopathy carried on for even in the subclinical ABMR folks. And so also in 2013, we learned about 2 phenotypes of antibody-mediated rejection. Phenotype 1 occurs early post-transplantation in the pre-sensitized. There's more options for these folks. Antibody-mediated rejection phenotype 2 is emergence of de novo DSA late post-transplant, and this is largely related to non-adherence on the patient side and maybe inadequate immune suppression exposure on our side. In this diagram, it shows the natural history of phenotype 2 antibody-mediated rejection. Here is the transplant. You have an early sensitizing event. Nothing happened. Creatinine is normal. You're carrying along. If you become curious and check de novo DSA, for de novo DSA, you may find them. They happen. They carry on. You start seeing inflammation afterwards. Creatinine may be okay in this period. You carry on, you form glomerulitis, and then it carries on to the chronic a rejection, a plus or minus cellular rejection, and then rising creatinine comes late. So what's the prognosis of phenotype 2 as compared to others? So in this Kaplan-Meier, it shows that, so all on the top, these are pre-existing donor-specific antibodies versus PRA with no DSA, PRA with negative, although small cohort, versus those who became sensitized after the transplantation and carried on to form de novo antibodies. They had worse outcome. So the influential factors, again, non-adherence or attempts on our behalf to minimize immune suppression. This may be our enemy or our hurdle to longer graft survival. Now we were aware of the notion of the CNI toxicity that carried on for early 2000s and by late 2000 with when we had more techniques to learn about different antibodies and how to measure them and how to quantify them, we came to the realization that chronic CNI toxicity may not be an entity, but that's a side note. Antibody-mediated rejection phenotype 2 carrying on may be related to the choice of the antibiotic. In this trial, this is a trial where the CNI was minimized or switched to everolimus at 3 to 4.5 months after transplantation. Everybody started with the same immune suppression, same induction. Everyone started with cyclosporin, carried on until 3 months to 4 months, where subset was switched to everolimus, and this is the incidence of donor-specific antibody formation, which was statistically significant, with more donor-specific antibody formed in the everolimus group, and on the second Kaplan-Meier, essentially what happened with these donor-specific antibodies, with the incidence of antibody-mediated rejection being higher in the everolimus group as compared to the cyclosporin. In terms of prevention of acute antibody-mediated rejection, BELA has been around for a few years, although, what we learned from BELA, it has a good handle on the antibodies. From the benefit and benefit extend trial, there were lower de novo DSA. Whether to switch someone who's on CNI to BELA would impact their donor-specific antibodies doesn't seem to be the case. So you may not get this benefit down the road. However, you get more cellular rejection with BELA as compared to the conventional immune therapeutics that we have. Moving on to the therapeutic options and the scant and limited evidence that we have. So we're going to go through different sites of the immune system that will impact the treatment of the antibody-mediated rejection. So here, these are our cells that cause the trouble. So on the antigen-presenting cells and the T cells, we have our steroids, thymoglobulin, BELA, that's their site of action with the co-stimulation blockade. And the B cells, the naive one, we have rituximab, we have IVIG causing them to slow down. We have the plasma cells and the Bortezomib introduction, plasmapheresis to remove the antibodies. And this is our poor endothelial cells. This is the complement and eculizumab site of action. So this is a tour through history from the 80s until now. What happened, what did not happen, or what was effective for treating antibody-mediated rejection in terms of plasmapheresis. So invariable results with plasmapheresis from the 80s to now, with either trend to harm or no treatment benefits or trend to benefit in the randomized trial, but these are a handful of patients. Carrying on to a more recent era that represent our current practices with more trend towards benefit for using plasmapheresis. And this is most of what we use for early antibody-mediated rejection. So rituximab is a chimeric CD20 monoclonal antibody that attaches itself to the naive B cells and lead to their demise. It was used to see how it can impact antibody-mediated rejection. It makes physiologic sense. However, here is some of the evidence behind it, or lack thereof. So in this group, they used therapeutic plasmapheresis, IVIG, rituximab versus high-dose IVIG alone. 24 subjects were assigned to each arm, and they compared the outcome. So in this study, the Rituxan was given at 2 doses weekly times 1 week 1 week apart, in addition to therapeutic plasmapheresis and low-dose IVIG in addition to steroids. And this is the antibodies plot. There was no reduction in those who received IVIG alone versus significant reduction for this group. Everybody was excited about Ritux at that point, and especially with the results. You have the combo group, Group B, had a better outcome as compared to those who received IVIG alone. However, this trial was reproduced in latter at a latter point. This still in abstract form. It was published in 2013. More subject assigned to Ritux versus placebo. All received plasmapheresis, IVIG, corticosteroids, tacrolimus, and Cellcept. And unfortunately, they were not. The Ritux was not superior to placebo in this trial. So we have naive cells that carry on to mature and go to the bone marrow and become more mature factory cells for antibodies. These are the plasma cells. So sensitizing event, you have your sensitized naive B cells carrying on, maturing to a plasma cell. So maybe this is the problem, and these are the cells that producing large quantity of antibodies. So pertuzumab was thought to be an option here, which makes sense. However, here I'm gonna share with you some of the trials. So pertuzumab is a proteasome inhibitor with unique ability to inhibit plasma cell. It's usually combined with IVIG plasmapheresis. It's given in 4 doses. That's a cycle of treatment. Pertuzumab is used otherwise for myeloma. So here, this is the first trial. I'll share with you 16 kidneys and 4 kidneys with combined organ. All had Novo DSA formation, peritubular capillaritis, C4D on biopsy, or conditioned with corticosteroids, followed by pertuzumab in the 1, 4, 8, and 11, in addition to plasmapheresis. Then they will sealed off with 2 grams of IVIG divided in 4 doses. And here, this is the graft survival after antibody-mediated rejection by the degree of the renal dysfunction. So for those who received this treatment while their creatinine was less than 3 and had less than 1 gram of protein in the urine, they appear to have gained good benefit as compared to those who were picked up late and had higher serum creatinine and higher protein creatinine ratio greater than 1. And this is what happened to the donor-specific antibodies. From this study, the notion that if you use pertuzumab earlier, before it's too late, there may be some benefit to it. This is an effort by Steve Woodall and others to look at early and late acute antibody-mediated rejection, and they do differ so they looked at people with antibody-mediated rejection early versus late, and they concluded that subjects with early antibody-mediated rejection differ than those who have late antibody-mediated rejection, and therefore that may be the reason why pertuzumab worked for some, not for others. And here, this is the early rejection under the treatment with pertuzumab, and this shows that their antibodies dropping. This is the late rejection. Once there was some effect, however, it was not as pronounced as for those subjects with early rejection. Another group reproducing similar results with pertuzumab in the early post-transplant, and this is creatinine, this is GFR. Those who received it were able to restore their allograft function if they received it early, if they rejected early, received it early, as compared to those late post-transplant who rejected later. They gained some benefit, but not, again, not as brisk, which perhaps this is, the two are perhaps 2 different groups, different phenotypes. Early, that what happens in the first few months or weeks after the transplant. The later antibody-mediated rejection, that takes place beyond the 6 months point, although these are all arbitrary definitions. So this is a comparison between the Bortezomib and the Rituxan. This is, comes to us from Germany. In here, there was no statistical significance, although there was trend towards Bortezomib being more efficacious, although it's just a trend that Bortezomib outperformed Ritux in a very small group. Now moving on to a different therapeutic intervention with the Eculizumab. It's a recombinant humanized monoclonal antibody against the activated C5 complement step. Doses are typically 600 milligrams is the lowest. Some use 1,200 milligrams. I'm going to share with you two reports. One from Hopkins. This is synthesized. That's a transplantation across HLA barrier subject who received desensitization leading up to the transplant. Things start working, although there was a major drop in urine output. The diagnosis was made for antibody-mediated rejection. You see in this line, this report is from 2009, so it predates what most people do right now. So here, this is the titers of the cytotoxic cross-match, and this is when the Eculizumab was introduced at this point, and you see response and the urine output following the introduction a few days later, in addition to the rest of the treatment, urine output was restored. Estegall from Mayo Clinic employed the Eculizumab in their pre-sensitization protocol, using it for desensitization and looking at the chance of rejection afterwards. Early on, they had promising results by 1 year, and this is the table. It shows here. Hopefully, you can see the projection. So, graft survival at 1 year for the Eculizumab group, 16 out of 16, versus the 49 out of the 51. Rejection TG by year 1 was very favorable for the Eculizumab group. By 2 years, the benefit was not sustained. Splenectomy is an option that's usually reserved for those who have severe anuric antibody rejection while still in the hospital early on post-transplant. And it's typically, I've seen it a handful of times in the subjects who are transplanted across HLA barriers. They will go on to carry on to splenectomy. This is a Hopkins report by Dr. Luck as well, and they published a case series of 5 and showing after they had to do splenectomy, the effect on the donor-specific antibodies, and they reserve it for those who become anuric and fail all other non-surgical interventions for antibody-mediated rejection. So there's surgical treatment for antibody-mediated rejection that preserved. So I thought to include this in the slides. We're not going to go into the details of the consensus guidelines. Now we know there's phenotype 1, phenotype 2 of antibody-mediated rejection. People will have the tendency to form donor-specific antibodies through their course of transplantation. So is there any relevance or is there any role to monitor our subjects after kidney transplant for donor-specific antibodies emergence, and what would we do about them? So these smart guys sat down, looked at all the literature, talked to one another, and came up with some guidelines to help us stratify our subjects and look at their DSA moving forward and intervening with a biopsy, or perhaps not relaxing our immune suppressions or minimizing if the donor-specific antibodies, and perhaps that will be one way that we can improve the long-term survival. Again, perhaps in speculation, no solid evidence. But to recap what we talked about, this is a different depiction of the slides that I showed you earlier. So that's the time. These are days from transplantation. This is the probability of survival. These are different causes, what happens to the allograft and what impacts survival most. And if you follow the blue line, this is antibody-mediated rejection. Claims most of the kidneys 5 years on or later on. So this is the most common cause for losing allografts as compared to any other cause. This is a conclusion of the therapeutic options that are present for antibody-mediated rejection and their site of action. In summary, acute and chronic antibody-mediated rejection play a critical role in all kidney allograft loss. Antibody-mediated rejection is our current barrier to long-term allograft survival. Treatment is most successful early on, in the first year perhaps, or first 6 months. No consensus on how to treat antibody-mediated rejection later on. Late ABMR or phenotype 2 carries far more worse prognosis than the former, and whether surveillance for late antibody-mediated rejection or donor-specific antibodies will have a value, this is a lesson to be learned over the next few years. Now, what's in the pipeline? There are three things that we learned about recently. C1 esterase inhibitor that is used for angioedema. It blocks the complement pathway at a higher point than the C5a, and received FDA approval to be used for the treatment of antibody-mediated rejection, and makes sense for those who are getting pheresis and you're removing different aspects of complements to replace them with that. I think California, Mayo, and Hopkins will be publishing some reports soon. This is the new Ritux that is coming on in the next few months. That it's a fully humanized anti-CD20, and it seems to perform better than Ritux. Something of the past, IDIS is a cysteine proteinase, which is a stripped pyogen, developed for non-transplant use, but its impact on the antibodies, or all antibodies, is very significant. It wipes all the antibodies one has for 2 weeks only. So John Hopkins introduced that. They are employing it for their desensitization protocol, but we don't know we don't know much about it yet. They have trouble if they give even if they give IVIG with it. It's just it wipes it out. With this, I conclude my talk, and I thank you all for your attention.